This is a video demonstrating complex strabismus surgery simulated. The authors have no financial interest. Optimal surgical training is paramount during ophthalmic residency, and simulation procedures on animal eyes have been practiced since ages. The authors have previously described simulation of basic squint surgeries such as recession, resection, and plication on rectus muscles. Here we will be demonstrating complex strabismus surgeries simulated on goat's eye. Firstly, to simulate inferior oblique surgeries, an obliquely coached muscle and two recti, that is lateral rectus and inferior rectus, are simulated. To perform the Fink's procedure, inferior oblique is identified and hooked. It is disinserted close to the insertion and its free end is secured using a 6-0 vicryl suture. A point is then marked 6 mm inferior and 6 mm posterior to insertion of lateral rectus, and the disinserted inferior oblique is sutured at this point. For performing the Parkes recession, a mark is taken 2 mm lateral and 3 mm posterior to lateral end of inferior rectus insertion. The disinserted inferior oblique is then sutured to this point. To perform Elliott and Nankin's procedure, the disinserted inferior oblique is sutured just adjacent to lateral end of inferior rectus insertion. To perform total anterior positioning, the disinserted inferior oblique is sutured just anterior to the lateral end of inferior rectus insertion. For performing anteronasal transpositioning or the Stagger's procedure, the disinserted inferior oblique is being sutured just anterior to the nasal end of inferior rectus insertion. Now we will be demonstrating procedures on recti muscle. To simulate Fadden surgery, a rectus muscle is identified and hooked. Marks are then taken at 14 mm from insertion site on both ends of the muscle. It is then secured to the underlying sclera using 5-0 ethibond suture at its either ends to complete retroequatorial myopexy of Fadden. This is a vertical view depicting completed Fadden's procedure. To perform the Y-splitting procedure, a rectus muscle is identified and hooked. The muscle is split at 50% width using two lens hooks, and the two ends are secured with 6-0 vicryl and then disinserted from sclera. The two splitted ends are spaced 21 mm apart and recessed to the required distance from the insertion site. For performing full thickness transposition surgeries, 3 recti muscle are simulated. The two horizontal rectus muscle are secured with sutures and disinserted. These are then sutured just adjacent to the vertical rectus insertion to complete the procedure. Here we have also demonstrated placement of posterior augmentation sutures using 5-0 ethibond. To perform partial thickness transposition surgeries, the two horizontal recti are split at 50% width using two lens hooks. One end is secured with 6-0 vicryl and disinserted from sclera. The free ends of the two horizontal recti are then sutured just adjacent to the insertion of vertical rectus, and the procedure is completed. To perform the no split, no tenectomy Nishida's procedure, a 5-0 ethibond suture is taken at 50% width of both horizontal recti, about 8 mm from insertion site. These sutures are then passed close to the insertion of vertical rectus muscle, approximately 12 to 14 mm from the limbus to complete the procedure. To simulate the superior oblique muscle surgeries, superior rectus is hooked and retracted to expose the underlying superior oblique. The superior oblique is then hooked and folded upon itself. Sutures are then passed at suitable length to perform the superior oblique tucking procedure. 60-vital sutures are passed at both the ends and superior oblique tucking is completed. To perform posterior tenectomy of superior oblique, anterior 2 mm torsional fibers are identified and marked. These are then separated from the posterior fibers using a Vanna's scissor. The posterior fibers are disinserted and a long segment is resected, leaving behind the anterior torsional fibers intact. For performing the superior oblique loop tenotomy, the superior oblique muscle is disinserted. The loose end is secured using a 5-0 ethibond suture and scleral pass is taken through the insertion site. The suture is again passed through the free end of the muscle, leaving behind a loop of approximately 8 to 10 mm in length to complete the loop tenotomy of superior oblique. To perform the Harada-Ito procedure, anterior 2 mm torsional fibers are identified. These are separated from the posterior fibers using a Vanna's scissor. The anterior torsional fibers are secured using a 5-0 ethibond suture and these are disinserted. These are then advanced anteriorly and sutured posterior to insertion of lateral rectus approximately 8 mm from the insertion site. Trainees of our institute to polish their surgical skills. Thank you for your kind attention.